Thank you, Ranmini. Ayuvan, Namaste. First of all, let me thank All India Ophthalmological Society. Can you hear me?
Yes, we can hear you, Chameera.
So, Namaste. First of all, let me thank All India Ophthalmological Society for inviting me to do this presentation. We all know ptosis is a common oculoplastic problem. Even though its management looks simple and straightforward, journey for a successful outcome is always a challenging one. On this way, there can be many pitfalls where you can fall into and get into unexpected troubles. But if you are smart enough to identify these pitfalls in advance and avoid them, you can make sure the end results will never be an unpleasant one. So let's try to be familiarized with some of these pitfalls, the reason, and know how to avoid them. The ptosis management includes the diagnosis, decision on treatment, surgical procedures, and post-operative care. The pitfalls can be encountered in all 4 stages. Let's start with pitfalls in the stage of diagnosis. Going through a few cases, this lady came with a complaint of my right eye looks smaller for more than 1 year. So what is your observation? Yes, she got right brow ptosis. Unlike in facial nerve palsy, when you have a isolated brow palsy with particularly subtle ones, you can easily overlook. However, you can't afford to miss this. Make sure that you detect this. This lady again came with small right eye for about 8 months duration. There was no proptosis. So what could be the cause? This is how when the lid was everted and the biopsy confirmed marginal zone lymphoma. Again, this slide shows 3 similar cases. Ptosis coming with subconjunctival retention cyst, prolapsed orbital fracts, and conjunctival amyloidosis. So you must remember to evert the upper lid and examine the fornix in every ptosis patient. This 65-year-old female came with ptosis for 2 months duration. There was no proptosis, no upper lid fullness. The eye movements were normal. Since there was no significant clinical finding, but due to short history, we decided to image. The CT scan showed small soft tissue lesion in relation to the levator muscle, and the biopsy confirmed an inflammatory pathology. So remember, if you are in doubt in any ptosis patient, don't hesitate to image them. Again, this gentleman came with left upper lid ptosis for 1 year duration. So what could be the problem? Yes, it is floppy lid syndrome coming with ptosis. So you must make sure that you attend to the floppy lid before doing any ptosis surgery. Actually, this is the only case which is not from my clinic. I chose it after doing an internet search to give you an important message. So what is the cause for the small right eye in this lady? Yes, it is hemifacial spasm. This is how she was after Botox injection. So you must remember that hemifacial spasm can present with small eye, particularly it can be easily missed when the early stage where the lower part of the face may not be much involved, as well as when the patient is wearing a mask, particularly with current pandemic situation. This is an interesting case. This young boy came with right ptosis following a head trauma. Things that usually come to our mind are the third nerve palsy, levator dehiscence, or Horner syndrome. But when you see the image below, when the left eye is closed, the right eye ptosis gets completely reversed. When the both lids were open, he complained of double vision and the Hess chart said right superior oblique palsy. So what has actually happened here? The patient had subconsciously keep his right eye closed to get rid of the double vision. So this ptosis is a compensatory ptosis. So you must make it a point to cover the other eye and examine in all cases of unilateral ptosis. This thyrotoxic lady came with right droopy eye, that no proptosis, eye movements normal. We thought about myasthenia gravis. We did all the investigation, but all negative. So we went again for imaging. The CT scan showed enlarged levator superior rectus complex in the left side where there's no ptosis. So how are you going to explain right eye ptosis in this patient? It's like this. Because of the left levator inflammation, it leads to subtle retraction, and this in turn leads to less innervation to levator muscles. According to Herring's law, there will be less nerves torn to the right levator, leading to right ptosis. So remember the Herring's law: paired eye muscle receive equal innervation. And this patient had right ptosis with lid retraction. So it is, what is the possibility? So it can be right ptosis with Herring lid retraction in the left eye, or it can be the vice versa. But if you look very carefully, what he has is lateral canthal dehiscence leading to lid retraction and short palpable fissure. So before doing any ptosis surgery, you have to fix the lateral canthal and examine for the new lid positions. Coming for the pitfalls in the stage of choosing treatments, this 14-year-old boy came with a ptosis following a dog bite, which occurred 7 years back. He had poor levator function and had 7 brow suspension without lid position improvement. So can you understand the problem? Because of the dog bite, the frontal branch of the facial nerve has got injured, causing left frontalis muscles to paralyze. So how come? Then obviously paralyzed frontalis can't lift the lid. So it is important to remember and check for the brow function before doing brow suspension. This lady again came with levator function for 12 months in both eyes. So what is your treatment plan? When you look, you can see the both brows are overacting as a compensatory mechanism. But despite that, he has not only the right, there's a left mild ptosis. So if you correct only the right eye, it is sure that the left lid will fall down when the compensation ceases. So you must do bilateral levator surgery in this patient. So remember this kind of latent ptosis and you should not miss it. This girl had right ptosis with lower lid retraction. So if you correct only the right upper lid, definitely she will have a very wide eye, which will give you a cosmetic problem as well as the risk of exposure. So you should not overlook lower lid retraction and should correct before doing ptosis surgery. Coming to the pitfalls which happen during the ptosis surgery. So usually we target a lid position which is in the range of 1 millimeter from the limbus, superior limbus. However, we can't keep the same target in all patients. In that case, we can fall into trouble. For example, this lady with Kern cell syndrome had bilateral ptosis with external ophthalmoplegia. She also had poor bells. Because of that, we could not compromise her lid closure. So we did only a partial correction of ptosis. So the visual axis is clear and the same time lid closure is preserved. Remember, safety is more important. Again, ptosis surgery is a cosmetic procedure. The overall look at the end of the procedure is what makes the patient satisfied. So these two patients had right levator surgery and has very good lid height and a shape. But if you see, the two lids are asymmetric. The contour is different and they are not alike. So what we usually think is making a lid crease incision identical to the other eye give you a post-op symmetry, but that is a wrong understanding. If you look at these two patients who underwent left levator surgery, has very good lid contour with symmetrical pretarsal show, brow fat span, and lid skin fold. This kind of aesthetic finish can be achieved only by contouring residual lid skin, preaporotic fat, descended roof fat, and the septum. Remember, this will not depend on lid crease incision alone. Coming to the last part of the topic, pitfalls in the post-operative care. This lady with right ptosis came 4 weeks after the surgery saying, "Doctor, my lid swelling has gone, but my is still small." So what do you think I did? Well, I did nothing. I waited for another 2 months, and this is how she was after that. So remember that you should not rush for any correction, post-op under correction, post-op under or over correction. So it is important to wait for 3 months before doing any touch-ups. Same way, this patient had bilateral levator surgery, and her eyes were not very perfect. Again, we waited for 4 months, and this is how she was at the end. So believe me, waiting is a very good management option during the post-op period. This girl had the right brow suspension but has residual ptosis. So what do you want to do? Do you want to go and redo and augment it? See, here is the problem is that her lid frontalis muscle. So what she has to do is practice to use the frontalis muscles to get the lid lift. And this is again, patient had bilateral levator advancement, and she was not happy about her left eye. Again, I covered the right eye. Left eye was perfectly okay. So what's the problem here again? So the patient has had uncorrected exotropia, giving rise to the impression of residual ptosis. So remember, not only the vertical strabismus, even the horizontal strabismus need to be corrected before ptosis surgery for a better cosmetic outcome. And this is the final case. This patient had right ptosis and operated by a plastic surgeon, came to me claiming right eye is too wide and ugly. In fact, the plastic surgeon has offered her to revise the surgery. Can you guess what I did? I did left side levator advancement, and this was the post-op appearance, and she was happy. So what has happened is she has had left latent ptosis, and which has got apparent after the right eye ptosis. So compensation has shifted from right to left, giving rise to the innervation, nerve innervation to both eyes, which is got aggravated, leading to right lid retraction. So the take-home message, so beware of brow ptosis, examine underlid and the foci lids, facial spasm, do imaging if no obvious cause, think about Herring's law in all stages, check brow function before brow suspension, don't overlook compensated ptosis, correct lower lid retraction and squint before ptosis surgery, ensure safety before aesthetic look, manage pre-tarsal show and the brow fat span for better post-op look, and don't rush for post-op touch-ups. One final word, your patient may be having limited visual field due to ptosis, but as the treating clinician, you can't afford to have a limited view. So I hope this presentation helped you to have a wider view toward the ptosis management so you can go a safe journey without falling into pitfalls. Thank you very much.